Welcome, colleagues and students, to this comprehensive masterclass on the biomechanics of the straight wire appliance. We will explore the foundations, mechanics, and clinical applications of one of the most influential systems in orthodontics. Now, I want to begin with a reminder. Orthodontics is not just about wires and brackets. It is about controlled biological tooth movement. Our appliances are merely tools to deliver forces. And like any tool, their effectiveness depends on how we use them. The Straight Wire Appliance, or SWA, was developed by Lawrence Andrews in 1970. His goal was simple but revolutionary: to create an appliance that would consistently achieve what he called the 6 keys of normal occlusion. Those 6 keys: molar relationship, crown angulation, crown inclination, absence of rotations, tight contacts, and a flat occlusal plane, became the gold standard for ideal occlusion. Think of this. Before Andrews, orthodontists spent endless hours bending wires. Every little torque, every tip, every in and out adjustment had to be placed manually. Andrews' idea was to build those prescriptions into the brackets themselves, so that once a bracket was positioned correctly, the desired tooth movement would happen naturally. But as you'll see throughout this lecture, the story does not end with brackets alone. The real artistry lies in bracket placement, in the sequence of wires, in anchorage planning, and in finishing. So today, my aim is to take you beyond the textbook definitions. I want to unpack these mechanics in plain teaching language. I'll use analogies, real-case examples, and even comparisons to architecture and engineering, because biomechanics is the architecture of teeth. By the end of this masterclass, you should feel confident not only in explaining how the straight wire appliance works, but in applying it to the wide variety of malocclusions we encounter in everyday clinical practice. Historical context and philosophy. Let us begin with the origins. In 1970, Lawrence Andrews introduced the SWA, and by 1972, he published his landmark paper on the 6 keys of normal occlusion. His philosophy was this: if we can design an appliance that already contains torque, tip, and in-out built into the bracket, we can reduce wire bending, standardize outcomes, and increase efficiency. This concept was revolutionary because it shifted the orthodontist's role from wire bender to bracket placer and force manager. It also standardized treatment goals. No longer was it just about aesthetics or subjective judgment. Andrews gave us measurable criteria for what constituted ideal occlusion. But let me make something clear. Andrews never claimed that SWA would magically fix every malocclusion. He understood that unwanted movements, like canine tipping or molar rotations, could still occur, especially in extraction cases. That is why he later developed extraction or translation brackets with overcorrections. Then came Roth in the mid-1970s. Roth recognized that when appliances were removed, teeth tended to rebound. He also observed that the large bracket sizes at the time caused interference, so he modified Andrews' prescription slightly, building in overcorrections to allow teeth to settle into ideal positions after debonding. This became the Roth prescription, which remains one of the most widely used in the world today. The key philosophy here is this: orthodontics is not static. Appliances evolve, prescriptions evolve, but the fundamental requirement remains. We must understand the biology and mechanics deeply, otherwise even the best appliance becomes ineffective. Appliance design and core values. So, what makes an appliance a true straight wire appliance? According to Andrews' original definition, 3 design features must be present. First, each bracket must be tooth-specific, with built-in torque, tip, and in-out. A central incisor bracket is not the same as a canine bracket. This tooth specificity ensures that once the wire engages, each tooth receives the correct directional force. Second, the torque must be built into the base of the bracket, not the face. The tip, however, belongs in the face of the slot. Why does this matter? Because if torque is placed on the face rather than the base, you disrupt the transfer of information from the bracket to the tooth. Precision is lost. Third, the base of the bracket must be contoured both mesiodistally and occlusogingivally, what Andrews called a compound contour base. This allows the bracket to adapt closely to the convex surface of the tooth, ensuring stability and accuracy in placement. Think of it like tailoring a suit. If the fabric is cut flat, it won't sit properly on a curved body. The same is true with brackets. A flat base on a convex tooth will rock, bond poorly, and transmit forces inaccurately. Now, if any one of these three requirements is missing, you do not truly have a straight wire appliance, no matter what the marketing says. And this is a critical point. Many so-called SWA systems on the market fail to meet these exacting standards. They may have torque and tip, but without compound contour, or with torque misplaced, the mechanics simply will not deliver as designed. Overcorrections and prescriptions. Now let's talk about overcorrections, because this is where Andrews and later Roth refined the system further. In extraction cases, for example, when a canine is moved distally on a round wire, it tends to tip and rotate. To counteract this, Andrews developed extraction brackets with extra mesial tip and built-in rotation. Later, these became known as translation brackets. But the problem was inventory. Imagine having to stock not only standard brackets, but also extraction versions for each tooth. It was cumbersome and commercially impractical. That's partly why the complete Andrews system never dominated. Roth simplified the concept. He took Andrews' standard prescription, added certain overcorrections where relapse was common, and created the Roth setup. His brackets anticipated rebound and post-treatment settling, making outcomes more predictable. From then on, numerous clinicians introduced small modifications to either the Andrews or Roth prescriptions, sometimes to suit their personal mechanics, sometimes purely for commercial branding. But the underlying principle remained. The appliance must deliver precise, pre-programmed information to the tooth, provided we position the bracket correctly. And that is where we now transition, from design to placement. Because no matter how perfect the bracket design, if you place it incorrectly, the information is lost. In the next section, we'll look closely at optimal bracket placement, and why Andrews said you begin finishing your case the day you bond your brackets. Self-ligation in the straight wire appliance. Let us now shift our attention to self-ligation, because this development has been both popular and controversial in orthodontics. When we talk about self-ligating brackets, or SLBs, we must first separate marketing myths from biomechanics reality. There are two main types, active and passive. Active SLBs have a clip with a spring effect. This clip presses the arch wire against the base of the slot. The amount of pressure depends on the wire size and the bracket design. Passive SLBs, on the other hand, have a gate that simply closes over the wire without pressing it into the slot. They are sometimes described as tubes with doors. Now, why does this matter clinically? In the early stages of treatment, when we use small, round, thermal wires, both active and passive systems behave quite similarly. There is little resistance to sliding, and alignment progresses well in either system. But as we move to the working and finishing stages, differences become apparent. Torque expression. The ability of the bracket to transmit its built-in prescription to the tooth is more reliable in active SLBs. Passive SLBs often underexpress torque, especially in rectangular wire stages. So here is the clinical pearl. If you depend on precise torque control, as we often do in finishing, active self-ligation provides a measurable advantage. But beware. Simply being self-ligating does not automatically make a bracket a true straight wire appliance. To qualify as an SWA, the bracket must still meet Andrews' original design requirements: tooth specificity, torque in the base, tip in the slot face, and compound contour. Without these, self-ligation becomes just a marketing label, not a biomechanical upgrade. Analogy and clinical perspective. To put it in everyday terms, think of passive self-ligation as a sliding door. It lets you move furniture in and out easily, but it doesn't push anything into place. Active self-ligation is more like a spring-loaded door. Not only does it close, but it pushes the object firmly against the wall, ensuring contact and stability. In orthodontics, that push makes the difference between torque being partially expressed or fully expressed. Clinical experience shows us that in cases where anterior torque is critical, such as camouflage treatment of Class 3 cases or correction of Class 2 Division 2 cases with retroclined incisors, passive SLBs frequently fall short. The incisors end up under-torqued, compromising both function and aesthetics. On the other hand, in simpler cases with minimal torque demands, passive SLBs may perform adequately. But as a rule, I encourage clinicians not to choose brackets based on fashion or sales pitches, but on the biomechanical requirements of their cases. Transition to bracket placement. Now that we've examined design and self-ligation, let us move to the critical clinical skill that determines success with the straight wire appliance, bracket placement. Remember this. When you use a SWA, you start finishing your case on the very first day of bonding. Unlike older techniques, where the orthodontist could bend in corrections as treatment progressed, SWA depends on the precise transfer of information from bracket to tooth. If a bracket is placed too high or too low, too mesial or too distal, that error propagates through the wire and distorts the entire occlusal scheme. One misplaced bracket may cause mild discrepancy, but multiple misplacements can accumulate into a clinically significant disaster. Rotations that persist, marginal ridges that don't level, roots that are not parallel. And here is the sobering truth. Many treatment failures that clinicians blame on the system are actually due to bracket positioning errors. The FA point and tooth specific considerations. So how do we avoid these errors? Andrews emphasized the importance of the FA point, the facial axis of the clinical crown. This is the midpoint of the crown occlusogingivally and mesiodistally, aligned along the tooth's long axis. This FA point is the reference for bracket placement. Several nuances are worth remembering. Canines. The most convex part of the labial surface is slightly mesial to the true center. If you place the bracket dead center, the tooth will rotate mesially. Always respect the FA point. Molars. The buccal groove is the long axis landmark. The tube should be centered on this groove, midway occlusogingivally. Modern tubes are often shorter mesiodistally, so orthodontists sometimes place them too mesially, producing distal over-rotation. Lateral incisors. These are notorious for variability in size and shape. In such cases, rely on the lingual surface to project the true long axis. Premolars, especially second premolars, visibility is poor. Use both occlusal and buccal mirrors to verify the FA point. What about gauges? Some orthodontists rely on bracket height gauges measured from the incisal edge, but Andrews himself argued this is not reliable because crowns vary. Teeth may be worn, fractured, or restored. Rigid height rules ignore the natural FA point, which is the true biomechanical reference. So remember this principle: trained eyes are more valuable than mechanical gauges. A clinician who learns to consistently find the FA point without aids will finish more cases successfully than one who depends blindly on fixed measurements. Transition into treatment mechanics. Up to this point, we've laid the foundation, we've explored the philosophy, the design, the evolution of prescriptions, self-ligation, and the principles of bracket placement. Now, we come to the heart of our discussion. Treatment mechanics using the straight wire appliance. For teaching purposes, different authors have divided mechanics into anywhere from 3 to 7 stages. But simplicity is key when we teach. And therefore, in this masterclass, we will follow a 3-stage model. 1. Stage 1, leveling and aligning. 2. Stage 2, the working stage. 3. Stage 3, the finishing stage. Each of these stages has unique goals, unique wire sequences, and unique biomechanical considerations. Let us begin with Stage 1. Stage 1. Principles of leveling and aligning. Leveling and aligning is deceptively simple. At first glance, it looks like just getting teeth straight, but if you look more deeply, you realize this stage sets the anchorage, the rotations, and the occlusal plane for everything that follows. During leveling and aligning, all crowns are moving simultaneously, but in different directions. Reciprocal forces develop between teeth, and if harnessed wisely, these forces can work to our advantage. Here's the principle: when possible, we should engage all teeth from the beginning, even those severely displaced. Why? Because engaging more teeth allows reciprocal forces to balance out and increases efficiency of tooth movement. The wires used at this stage are typically small, round, thermal-activated nickel titanium wires. Think of them as flexible guide wires that begin the process of organizing the chaos. Wire selection. Early phase. For severe crowding, the wire of choice is usually a 0.014-inch centalloy super-elastic knee-T. For moderate to minimal crowding, we often begin with 0.118-inch centalloy. These wires are light, flexible, and able to deliver gentle, continuous forces over long deflections. They stay in the mouth for 8 to 12 weeks, slowly unraveling the crowding. Now, let me emphasize a critical clinical point. At this stage, avoid rectangular or square wires. Some clinicians, eager to save time, attempt to introduce torque early by placing rectangular knee-T wires. But this is a mistake. Why? Because it risks posterior anchorage loss. The only teeth with positive labial crown torque are the maxillary central and lateral incisors. The canines, by contrast, have significant mesial crown tip. If we start with rectangular wires, we unintentionally provide labial crown torque to the incisors and mesial tip to the canines. This increases anterior anchorage demands and causes posterior anchorage loss, disastrous in cases requiring maximum incisor retraction. Wire selection, transitional phase. After 8 to 12 weeks, when initial rotations are corrected, we typically move to a transitional wire such as 0.020 Bioforce nickel titanium. This wire is square, not round. It continues alignment, provides more stiffness, begins to level the curve of SPE, and gently flattens the occlusal plane. Importantly, it activates the clip of active self-ligating brackets, introducing controlled torque, but not so much as to jeopardize anchorage. In certain cases where incisor retraction is critical, some clinicians may substitute a 0.020-inch round stainless steel or centalloy wire instead of the 0.020 Bioforce. This avoids introducing unwanted torque while still allowing posterior leveling. This is the essence of biomechanics: decision-making, matching the wire to the anchorage needs of the case. Goals of Stage 1. So, what exactly should we expect to achieve in Stage 1 before moving forward? Teeth move individually, mostly crown movement rather than root movement. Molars and premolars derotate and upright distally. Incisors begin to upright. Sometimes they even retract spontaneously because of reciprocal forces. Posterior anchorage starts to build. The occlusal plane starts to level. Most importantly, bracket placement errors become visible, and this is the first checkpoint to debond and rebond any brackets that are grossly misplaced. This is a crucial step many overlook. Do not carry bracket errors into the working stage. Stage 1 is your first opportunity to correct them. Case correlation and analogy. Let me illustrate with an example. Imagine a crowded Class 1 case with proclined maxillary incisors. We begin with 0.014 centalloy, then progress to 0.0118. Crowding resolves, molars upright, and suddenly, without any retraction mechanics, the incisors appear more upright. This is the so-called lasso effect, where posterior uprighting naturally retracts anterior teeth. This is a gift of biomechanics. But it only happens if we resist the temptation to start too aggressively. Think of Stage 1 as clearing the construction site. You don't pour the foundation of a building on uneven ground. First, you level, you align, you prepare. That is what this stage does for orthodontics. Once these foundations are set, we are ready to progress to the heavy lifting. Stage 2, the working stage. Introduction to the working stage. Now that the teeth are aligned, the arch is leveled, and anchorage established, we arrive at Stage 2, the working stage. This is where we spend the largest proportion of treatment time. Why? Because this is the stage in which the true orthodontic corrections occur. It is here that we coordinate the upper and lower arches, achieve proper overbite and overjet, correct Class 2 or Class 3 relationships, align midlines, closed extraction spaces, parallel the occlusal planes of the maxilla and mandible. If Stage 1 was the excavation and leveling of the construction site, Stage 2 is the erection of the framework of the building, the walls, beams, and floors that give the structure its shape. Get this wrong, and no finishing can truly compensate. Arch coordination. Let us begin with arch coordination. For a stable occlusion, we need proper intercuspation. In an ideal Class I relationship, the palatal cusps of the maxillary molars sit into the fossae and marginal ridges of the mandibular molars. The buccal cusps of the premolars interlock with their maxillary counterparts. The canines and incisors intercuspate neatly with opposing marginal ridges. When this occurs, we see a consistent 2 to 3 millimeters of overjet throughout the arch. To achieve this, the maxillary arch wire must be approximately 2 to 3 millimeters wider than the mandibular arch wire. Although manufacturers provide preformed arch wires, clinicians must never assume these are perfectly coordinated. Always verify and adjust. Remember also the transverse dimension. If maxillary molars are tipped buccally, an accentuated curve of Wilson, they may contact only on palatal cusps, leading to a false open bite and even backward mandibular displacement. Solutions include 1. Allowing torque expression on full-size finishing wires for minor discrepancies. 2. Adding palatal crown torque manually to working wires for moderate issues. 3. Using a transpalatal bar, TPB, for significant discrepancies, delivering torque directly to molars. This is not a small detail. Proper arch coordination affects not only intercuspation, but also vertical and sagittal mandibular position. Overbite and overjet correction. Next, we consider overbite and overjet. An optimal overbite is around 4 millimeters, while an ideal overjet is 2 to 3 millimeters. But more important than the numbers is the function. The anterior teeth must guide occlusion in protrusive and lateral movements while allowing posterior disclusion. Arch space plays a crucial role. Leveling the curve of SPE requires space. If the arch is crowded and we flatten the curve without creating space, incisors procline, overbite decreases, and periodontal risks arise, especially in thin biotype patients. So, strategies for space creation include interproximal reduction, up to 4 to 6 millimeters safely. Extractions when greater space is needed. Another factor is mandibular position. Sometimes in maximum intercuspation, the bite looks normal, but in centric relation, it is open. This discrepancy must be identified early, often with the help of articulators or CBCT imaging. Finally, aesthetics must guide function. According to the upper sternum concept, in adolescents and young adults, the maxillary incisors should display about 4 millimeters at rest. This soft tissue reference helps us decide whether to intrude molars, extrude incisors, or both. Closing extraction spaces. Space closure is often the defining challenge of the working stage. By this time, initial alignment has consumed part of the extraction space, as incisors have uprighted and occlusal planes have flattened. Now the clinician must determine anchorage requirements. This is best visualized with a visual treatment objective, or VTO, modifying a cephalometric tracing to simulate desired outcomes, then planning biomechanics accordingly. We classify anchorage into 3 categories. 1. Minimum anchorage. Posterior teeth are moved mesially to close space, used when anterior position must be preserved. 2. Medium anchorage. Reciprocal closure. Space is shared between anterior retraction and posterior mesialization. Most common scenario. 3. Maximum anchorage. Most of the space is closed by anterior retraction. Posterior teeth are kept stable using TPB, TADs, or even headgear. Choice of anchorage determines wire size and auxiliaries. Wire choices and space. Closing mechanics. Let's discuss mechanics. The wires of choice here are 0.025-inch stainless steel or 0.021025-inch stainless steel, depending on anchorage demand. There are 2 main systems: double keyhole loop, DKH, wires activated by opening loops and cinching back. Stainless steel with hooks, used with centilloy coils delivering 100, 150, or 200 grams of force. Activation site depends on anchorage strategy. For minimum anchorage, activate from first molars. For maximum anchorage, activate from second molars with posterior reinforcement. The principle is this: anchor units must be strong, consolidated, and resistant, while active units are tied together as a group for retraction. Intermaxillary elastics. Another critical tool in the working stage is the intermaxillary elastic. But let me emphasize, discretion is key. Elastics are powerful, but if misused, they they create iatrogenic problems. We avoid elastics in these situations with round wires. In early leveling with low deflection wires. On terminal teeth, which cannot reciprocate forces. In anterior open bite closure with long vertical elastics, which can extrude incisors undesirably. For extended periods, which can distort occlusion. We use them judiciously in the working and finishing stages. With rectangular stainless steel wires, short vectors, such as class 2 elastics from maxillary canine to mandibular second premolar, to minimize side effects. Typically, we prescribe 3 16-inch elastics in 4, 6, or 8-ounce strength. The choice depends on desired force and patient compliance. Think of elastics as the fine-tuning ropes that pull the arches into harmony. Used well, they are transformative. Used carelessly, they destabilize anchorage and prolong treatment. Summary of the working stage. So, let us summarize what we achieve in the working stage. We coordinate arches transversely, ensuring intercuspation and correcting curves of Wilson. We establish functional overbite and overjet. We close extraction spaces with careful anchorage planning. We correct sagittal relationships, class 2 or 3, with elastics, mechanics, and sometimes TADs. We align midlines and parallel occlusal planes. In short, this stage transforms alignment into a stable, functional occlusion. It is the heavy lifting of orthodontics, the stage where mechanics, biology, and patient cooperation converge. Introduction to the finishing stage. We now enter the final stage of treatment mechanics, the finishing stage. This stage is where all the small details are polished. Think of it as cutting and polishing a diamond. The structure of the tooth movements has already been achieved in stage 1 and stage 2. Now, in stage 3, we add the brilliance, the sparkle, the fine articulation that makes a case truly exceptional. This is also the stage where we spend the least amount of time, provided earlier stages were done correctly. But it requires the sharpest eye, the most disciplined attention to detail, and the highest level of clinical precision. Wires, finishing, and bracket repositioning. The wires we use in finishing are typically large, rectangular stainless steel wires, 021, 025, or even 022, 028. These wires fully express the torque, tip, and in-out built into the bracket prescription. But in many cases, we do not stop there. We then use multi-braided stainless steel wires, which provide resilience and allow settling of occlusion without losing control. These wires are ideal for the final intercuspation stage, where small elastics can be applied to achieve cusp-to-fossa contact. And here is an important clinical pearl. The finishing stage is the ideal time to debond and rebond mispositioned brackets. No matter how careful we are at initial bonding, discrepancies become visible only when teeth are aligned and in working wires. If a marginal ridge discrepancy persists, or if a root parallelism error is seen radiographically, do not hesitate. Remove the bracket and reposition it. It is far more efficient to do this now than to try to bend wires endlessly. Finishing goals. So what are the objectives of the finishing stage? Complete intercuspation. Every cusp should sit neatly in a corresponding fossa or marginal ridge. Final torque and angulation. Roots must be parallel, crowns upright, occlusal plane flat. Midline correction. The dental midline should match the facial midline when possible, or be within 1 mm. Functional occlusion. In centric relation, centric occlusion, protrusion, and excursions, anterior guidance should be effective, and posterior teeth should disclude. Aesthetic finish. Smile arc should be consonant, gingival margins should be harmonious, and incisor display should be appropriate for age and sex. To achieve these goals, we may use short vectors of elastics, braided finishing wires, bracket repositioning, or even minor enameloplasty. But remember, the finishing stage is about refinement, not heavy mechanics. If you are trying to move teeth substantially in this stage, something went wrong earlier. Case studies and clinical pearls. Let us briefly revisit some case examples to illustrate finishing concepts. Case 1. A 20-year-old female with anterior open bite. After leveling, TPB use, and vertical elastics, the open bite was closed. Finishing required braided wires and short vertical elastics to achieve cusp fossa intercuspation. Case 2. a 14-year-old male with blocked canines and extraction spaces. After careful anchorage control and canine alignment, finishing required bracket rebonding on mandibular premolars to achieve parallel roots. Case 3. A 12-year-old girl with severe deep bite and retroclined incisors. After curve of speed correction and anterior torque control, finishing required elastic settling and reshaping of incisal edges for aesthetic harmony. These examples emphasize a simple truth. The final brilliance of treatment lies not in dramatic mechanics, but in attention to small details. Conclusion. Let us return to the philosophy of the straight wire appliance. It is not the brackets or the wires that make orthodontics successful. It is the understanding of biomechanics, the precision of bracket placement, the discipline of wire sequencing, and the vigilance of finishing. The straight wire appliance was revolutionary because it embedded orthodontic principles into the bracket itself. But in the hands of a careless clinician, even the best appliance fails. So my final message is this. Mastery is not about having the most advanced bracket or wire. Mastery is about applying timeless principles with consistency and precision. When you bond brackets, you begin finishing that very day. When you plan wire sequences, you are shaping the future occlusion, and when you polish the final details, you create not just alignment, but harmony, function, and beauty. Thank you for joining me in this journey through the biomechanics of the straight wire appliance. I hope these insights will guide your clinical practice, sharpen your understanding, and inspire you to pursue excellence in every case.